A man floats between consciousness and the void. Around him only the smell of ether, dried blood, and the distant murmur of doctors. He tries to open his eyes, but cannot. Not because he is too weak. It is because he no longer has eyelids. His face, once the mirror of his soul, is now a scarred mass of living tissue, fused and twisted by the heat of an explosion. He is Walter Yeo, seaman of the Royal Navy, and in a few weeks he will become the first human being in history to receive a reconstructed face through a technique that the medical establishment had rejected as impossible, dangerous, and even grotesque. This technique, the tube pedicle, was about to change medicine forever. To understand how we arrived at this turning point in surgical history, we need to go back a few years. It was early 1915, and a young New Zealand surgeon named Harold Delph Gillies had just landed in France as part of the Royal Army Medical Corps. Gillies was born in Dunedin, New Zealand on June 17, 1882. He studied medicine at Cambridge and specialized in otolaryngology in London, but nothing in his conventional training could have prepared him for what he was about to witness in the field hospitals of the Western Front. What was unfolding in the trenches of France and Belgium was a type of warfare that humanity had never experienced. The weapons had evolved in terrible ways. Heavy artillery, machine guns, poison gas, all designed to inflict maximum damage to the human body. And there was a cruel detail in the architecture of trench warfare. Soldiers spent hours, days, weeks with their heads exposed above the parapet, watching the enemy. The face was the target. Fragmentation shells were the most devastating. Designed specifically to shatter into hundreds of pieces of hot metal, they tore flesh, ripped away entire jaws, vaporized noses, destroyed eyes. What remained was often unrecognizable as human. The wounds arriving at field hospitals were unlike anything medical textbooks had described. Men arrived with their mandibles hanging by threads of tissue, their cheeks open to expose teeth and bone, their noses completely obliterated. The lucky ones were unconscious. The others screamed through what remained of their mouths. In French field hospitals, Gillies watched with horror the treatment given to these men. Surgeons simply stitched the irregular wounds without considering the amount of tissue lost. As the scars healed, the flesh contracted, pulling the face into grotesque and permanent grimaces. Some men were unable to eat or drink, others had to be kept sitting constantly to avoid suffocating when lying down. Many were blind, or had open holes where their noses used to be. The psychological impact was devastating. These were young men, barely in their 20s, who would never again be able to show their faces in public without causing terror in those who saw them. It was in this medical hell that Gillies began to question everything he knew about surgery. He had studied briefly with French surgeon Hippolyte Morestin, who worked with skin grafts to reconstruct the faces of cancer patients. Morestin had demonstrated that it was possible to move tissue from one part of the body to another, but his techniques were limited, infection rates were high, and results often disappointing. The fundamental problem was blood supply. When a piece of skin was completely separated from its original location and moved to the face, it frequently died before new blood vessels could grow into it. The tissue would turn black, rot, and have to be removed, leaving the patient worse off than before. When he returned to England in 1915, Gillies was obsessed with an idea: to create a specialized unit only to treat facial injuries. He argued tirelessly with his superiors in the Royal Army Medical Corps. The faces of these men could be reconstructed, he insisted. There was only one condition. They needed a hospital dedicated exclusively to this purpose, with trained surgeons, specialized equipment, and above all, time. Facial reconstruction was not something done in a single operation. It would be a process of multiple surgeries, extending over months or even years. His colleagues were skeptical. Plastic surgery, as it was known, had a dubious reputation. It was associated with frivolous cosmetic procedures, not serious medicine, and Gillies was proposing to dedicate an entire hospital to it. Nevertheless, his persistence paid off. In 1916, a small unit was established at Cambridge Military Hospital. The results, while modest, were promising enough that in 1917 a larger facility was opened, Queen's Hospital in Sidcup, Kent. This would become the cradle of modern plastic surgery. If you are finding this story compelling, consider subscribing to the channel and leaving your like. It helps us continue bringing stories like this. Now, let us return to Gillies' journey. Queen's Hospital was unlike any medical facility that had existed before. Gillies assembled a multidisciplinary team that included not only surgeons, but also dentists, anesthetists, nurses, and even sculptors and artists. The artists were crucial. They created masks for the men whose faces could not be reconstructed, but they also made detailed drawings and sculptures showing what each patient's face had looked like before injury and what it might look like after reconstruction. These visual aids allowed Gillies to plan his surgeries with unprecedented precision. The working conditions were extraordinarily difficult. This was before the advent of antibiotics. Sulfonamides would not become available until the late 1930s, and penicillin was not introduced until 1943. Without knowledge of bacterial infection in the modern sense, many patients had multiple dental infections, abscesses, and wounds that refused to heal. In this limited pharmacological environment, one of the precepts preached by Gillies was early surgical debridement of craniofacial lesions, which helped reduce local infection and brain abscesses. The other critical innovation came from anesthesia. Two pioneers worked with Gillies at Sidcup, Rubens Wade and Ivan McGill. Wade primarily worked with patients who needed to be seated during operations, usually if there was injury to the base of the head or back of neck. McGill pioneered endotracheal anesthesia, where the insertion of a plastic tube into the trachea created an artificial extension through which the patient could breathe and the physician could administer anesthetics. This kept the equipment used to anesthetize patients clear of the operating table and did not interfere with surgeons' aseptic techniques. For the first time, surgeons could work on a patient's face without having a chloroform mask in the way. Between 1917 and 1925, Gillies and his team operated on more than 5,000 patients. Some underwent a single surgery, others endured dozens of operations spread over years. The hospital became a small city unto itself, with recovery wards, rehabilitation facilities, and even recreational areas where patients could socialize away from the stares of civilians. Men arrived broken and left, if not whole, at least functional. They could eat, drink, breathe. Some could even smile. But the breakthrough that would define Gillies' legacy came in 1917 with a patient known in his notes as Seaman Vicarage, though some records also reference a patient named Willie. This man had suffered devastating injuries to the lower part of his face. The challenge was immense: how to replace missing tissue without the graft dying from lack of blood supply. Gillies proposed to raise what he called a Masonic collar flap of skin from the patient's chest to repair the lower part of the face. The technique involved cutting a long rectangle of skin and underlying tissue, but leaving it attached at both ends to maintain blood supply. This flap would be swung up toward the face. Traditional practice was to leave such flaps open, like a bridge of flesh connecting chest to face. But during the operation, Gillies noticed something crucial. The edges of the pedicle flaps curled in on themselves under tension. In a moment of surgical intuition that would change medical history, he made a decision. He decided to sew the edges together, forming a tube. The effect was immediate and dramatic. The risk of infection was reduced because the raw tissue was protected inside the tube. The blood supply was much better because the tube maintained the vascular connections more efficiently than a flat flap. The tube could also be moved more easily and was less susceptible to injury during the patient's daily activities. This was the birth of the tubed pedicle. The technique worked like a living bridge of flesh. One end of the tube remained attached to the chest, maintaining blood supply. The other end was attached to the face, near the site of injury. Over the course of 3 weeks, blood vessels from the facial attachment site would grow into the tube, establishing a new blood supply. Once this happened, the chest end could be cut away. The tube could then be opened and spread out to graft a much wider area if required. The results were nothing short of miraculous. Patients who would have been condemned to permanent disfigurement now had faces that, while not perfect, were recognizably human. They could go out in public without causing alarm. They could marry, hold jobs, live normal lives. Word of Gillies' success spread rapidly through military medical circles. But here is where the story takes an unexpected turn. Gillies was about to publish his discovery when he learned that a Russian ophthalmologist named Vladimir Filatov had already published a similar technique. Filatov, working independently in Odessa during the chaos of World War I and the Russian Revolution, had developed his own version of the tubed pedicle around the same time. This was not plagiarism. This was convergent evolution in surgical thinking. Two brilliant minds, separated by distance and unable to communicate due to war, had arrived at the same solution to the same problem. Today, we would share such discoveries instantly through electronic communication. In 1917, surgeons in England and Russia might as well have been on different planets. The fact that both independently developed the tubed pedicle speaks to the fundamental logic of the technique. It was an idea whose time had come, born from the desperate need to help men whose faces had been destroyed by industrial warfare. The tube pedicle was not without its critics. Some surgeons in the medical establishment viewed it with suspicion. The technique required multiple operations over weeks or months. Patients had to walk around with tubes of flesh connecting their chests to their faces, looking like something from a fever dream. Conservative physicians argued it was too radical, too experimental, too risky. They preferred traditional methods, even if those methods produced inferior results. This resistance is what the title refers to when it mentions the surgery being banned, though it was more accurate to say it was discouraged or dismissed by conservative elements of the medical profession. But results spoke louder than objections. The tubed pedicle worked. It saved faces and lives. Gillies refined the technique constantly, finding new applications. He used tubed pedicles to reconstruct noses, eyelids, lips, entire sections of jaw. He trained other surgeons in the method, spreading the knowledge throughout the Allied medical services. By the end of World War I, the tubed pedicle had become standard practice in reconstructive surgery. One of the most remarkable aspects of Gillies' work was his maxim, "Never throw away anything until you are sure you will not need it." This became a doctrine that perpetuated itself in all areas of plastic surgery and repair. In an era when surgeons often removed damaged tissue aggressively, Gillies insisted on preserving every scrap of viable flesh. You never knew when that small piece of skin or cartilage might be useful in a later reconstruction. This conservative approach to tissue management remains a fundamental principle of reconstructive surgery today. The psychological impact of Gillies' work cannot be overstated. Before his innovations, men with severe facial injuries often chose to end their own lives rather than face the world with their disfigurements. The horror of seeing one's own face in a mirror transformed into something monstrous was more than many could bear. Families sometimes rejected their wounded sons and husbands, unable to cope with the shock. Towns established special benches, painted blue, where facially injured veterans could sit. These benches served as a warning to civilians that the person sitting there might have a disturbing appearance, so they should not be alarmed. Gillies' reconstructions changed this equation. Men who received tubed pedicle surgeries might not look exactly as they had before, but they looked human. They could make eye contact. They could eat in restaurants. They could kiss their children without frightening them. The psychological healing that accompanied physical reconstruction was profound. Queen's Hospital became not just a surgical facility, but a place of hope. The technical innovations extended beyond the tubed pedicle itself. Gillies developed techniques for using the temporal muscle as a transposition flap for deformities caused by zygomatic loss. His inspiration came from German surgeons who used temporal fascia flaps to treat facial paralysis. Many surgeons started to use this flap to support and reconstruct the orbit. He reported and extensively demonstrated rhinoplasty techniques, which he applied in his private aesthetic practice. In 1932, he described the use of direct pedicle flaps rather than tubular flaps, which entailed only 2 surgical interventions in cases where the tubed approach was not necessary. Gillies also worked closely with Harvey Cushing, the great American pioneer of neurosurgery, on complex cases of combined facial and cranioencephalic lesions. The collaboration between plastic surgery and neurosurgery opened new possibilities for treating the most severely injured patients, those who had suffered damage not just to their faces, but to their skulls and brains. The scale of Gillies' achievement becomes clear when we consider the numbers. Over 11,000 surgical procedures on 5,000 men, each surgery planned with meticulous care, documented with photographs and detailed notes. The Gillies archives, stored at Queen Mary's Hospital in Sidcup, contain these case files. They are a testament to surgical innovation born from necessity. One case file, preserved in the Royal College of Surgeons archives, describes a patient who arrived with a transverse fracture of the right body of the mandible in the molar region. Drastic soft tissue injuries, including full thickness, loss of the lower lip and mucosa, a complex tongue laceration, and damage to the right cheek. Gillies identified a bony defect which had previously been stabilized and was healing, albeit inadequately. Using a combination of bone grafts and tubed pedicles, he rebuilt not just the soft tissue, but the underlying structure, creating a face that could function. The patient could speak, eat, and breathe normally. The tube pedicle technique Gillies pioneered would go on to have applications far beyond facial reconstruction. In the 1940s, Gillies used the knowledge he gained while operating on wounded soldiers to perform one of the first sexual reassignment surgeries. Beginning in 1946, he completed a phalloplasty by constructing an entirely new penis from skin and tissue with grafts on a patient named Michael Dillon. The procedure included 13 surgeries that took place in 5 stages over 4 years. Gillies started the process by creating an extension to the existing urethra with a tube of tissue, which he then surrounded by a pedicle using skin from the pelvic area and along the groin. This expansion of the tubed pedicle technique into reconstructive surgery for conditions beyond war injuries demonstrated the versatility of Gillies' innovation. The same principles that allowed him to rebuild a sailor's face destroyed by shell fire could be adapted to create entirely new anatomical structures. The tube maintained blood supply during the long process of tissue transfer and integration. It was a universal solution to a universal surgical problem: how to move living tissue from one place to another without killing it. When World War II broke out in 1939, Gillies was called back into service. He was no longer a young surgeon making his reputation. He was now the acknowledged master of plastic surgery, the man who had written the textbook, literally. In 1920, Gillies had published Plastic Surgery of the Face, which became the foundational text of the specialty. This book documented his techniques, illustrated with photographs and drawings, providing a roadmap for other surgeons to follow. During World War II, Gillies continued his work at Rooksdown House, part of the Park Prewett Hospital in Basingstoke, England. He expanded his scope because of the vast number of injuries and the small number of surgeons who had the necessary expertise to carry out the specialized techniques. He led and assisted with surgeries on blast wounds requiring reconstruction of various body parts. The principles he had established during the First World War remained valid: meticulous planning, preservation of tissue, maintenance of blood supply, and patience through multiple stages of reconstruction. It is worth noting that Gillies was not alone in developing reconstructive surgery techniques during the World Wars. Surgeons on all sides of the conflicts were faced with similar challenges and developed similar solutions. German surgeons contributed innovations in the use of temporal fascia flaps. French surgeons like Morestin pioneered early skin grafting techniques. Russian surgeons like Filatov worked on the tubed pedicle independently. The horrors of industrial warfare drove medical innovation across national boundaries. But Gillies stands out for several reasons. First, the sheer scale of his work. Over 11,000 procedures gave him an experience base that few surgeons could match. Second, his willingness to innovate and take risks. The decision to sew that first pedicle flap into a tube was not based on extensive research or careful experimentation. It was surgical intuition in the moment, a flash of insight during an operation. Third, his commitment to documentation and teaching. By publishing his techniques and training other surgeons, Gillies ensured that his innovations would outlive him and spread throughout the medical world. The legacy of the tubed pedicle extends into modern medicine in ways both obvious and subtle. While microsurgical free flaps have largely replaced tubed pedicles in contemporary reconstructive surgery, the underlying principles remain the same: maintain blood supply, preserve viable tissue, plan carefully, execute patiently. These lessons, learned in the brutal classroom of World War I, continue to guide reconstructive surgeons today. There is a human dimension to this story that must not be forgotten. Behind every surgical innovation, every technique, every case file, there was a man. A young man, often barely 20 years old, who had gone off to war with dreams and ambitions, who had been blown apart by high explosives and had to somehow find the will to continue living. The courage of these patients was as essential to the development of plastic surgery as the skill of the surgeons. These men underwent surgery after surgery, month after month, sometimes year after year. They endured pain, infection, setbacks, and disappointments. They walked around with tubes of flesh connecting their chests to their faces, objects of curiosity, and sometimes revulsion to those who saw them. They did this because the alternative was unthinkable. The alternative was to live the rest of their lives hidden away, ashamed of their own faces, unable to participate in normal society. Walter Yeo, the sailor whose story opened this narrative, was one of the first to undergo Gillies's experimental procedures. Yeo had been injured at the Battle of Jutland in 1916, suffering severe facial burns. Gillies used skin flap techniques to reconstruct Yeo's eyelids and face. While the exact details of whether Yeo received a true tubed pedicle are debated in historical records, he was certainly among the earliest patients to benefit from Gillies's innovations in pedicle flap surgery. The transformation was remarkable. Photographs show Yeo before and after reconstruction. In the before images, his face is a horror, raw tissue, and exposed bone where his eyelids should have been. In the after images, he has recognizable eyelids and a face that, while scarred, is unmistakably human. He could open and close his eyes. He could see the world again without the world recoiling from him. This was the promise that Gillies offered to every patient who came through the doors of Queen's Hospital. Not perfection, but humanity. Not beauty, but function. Not the face you had, but a face you could live with. For men who had lost everything in the trenches, this was more than enough. It was salvation. The tube pedicle remained in widespread use through the mid-20th century. Surgeons refined Gillies's original technique, developing variations for different anatomical sites and different types of reconstruction. The basic principle, however, remained unchanged. Cut a flap of tissue, but leave it partially attached. Form it into a tube to protect the raw surfaces and optimize blood supply. Move it in stages to the reconstruction site. Wait for new blood vessels to grow in. Detach the original blood supply. Open the tube and use the tissue to rebuild what was lost. It was a slow process, sometimes taking months to complete a single transfer. Patients had to be extraordinarily patient, living with these tubes of flesh as they slowly migrated from donor site to recipient site. But it worked, and in an era before microsurgery, before the ability to reconnect tiny blood vessels under high magnification, the tubed pedicle was often the only option for transferring large amounts of tissue safely. The decline of the tubed pedicle came with the rise of microsurgical free-flap surgery in the 1970s and 1980s. With operating microscopes and specialized instruments, surgeons could now completely detach a piece of tissue from its original blood supply, move it anywhere in the body, and reconnect the blood vessels to recipient vessels at the new site. This allowed tissue transfer in a single operation rather than multiple stages. The tubed pedicle, which had reigned supreme for over half a century, became a technique of historical interest rather than current practice. Yet the principles Gillies established remain relevant. Modern reconstructive surgeons still preserve tissue aggressively. They still plan meticulously. They still think in terms of blood supply and tissue viability. They still understand that reconstruction is a process, not an event, often requiring multiple operations over time. In this sense, every reconstructive surgeon practicing today is a descendant of Harold Gillies, whether they realize it or not. Gillies himself lived until 1960, dying at the age of 78. He had witnessed his specialty grow from a controversial experimental field to a respected branch of surgery. He had trained generations of surgeons who went on to establish plastic surgery units around the world. He had written the textbooks that defined the field. He had pioneered techniques that saved thousands of lives and restored thousands of faces. His knighthood, awarded for his services during World War I, recognized not just surgical skill but humanitarian impact. Gillies had looked at men whom others considered beyond help and had seen possibility. He had taken surgical techniques that others dismissed as too risky and had proven them safe and effective. He had created a hospital that was as much a place of psychological healing as physical reconstruction. In the end, the story of the tubed pedicle is a story about refusing to accept limitations. The medical establishment said it could not be done. Conservative surgeons said the risks were too high. Traditional techniques, while inadequate, were at least familiar and safe. But Gillies looked at a pedicle flap curling in on itself during surgery and saw an opportunity. He made a decision in the moment that would echo through decades of surgical practice. He sewed those edges together, creating a tube. That tube rebuilt faces. It gave men back their humanity. It established the principles of modern reconstructive surgery. It proved that innovation often comes not from careful laboratory research, but from surgical intuition in the operating room, from the willingness to try something new when the old ways are failing, from the courage to take a risk when a patient's life or quality of life hangs in the balance. The 3 weeks mentioned in the title refers to the typical time it took for a tubed pedicle to establish sufficient blood supply at its recipient site to allow the donor end to be detached. 3 weeks during which the patient lived with this strange appendage, this tube of living flesh connecting one part of their body to another. 3 weeks of hope and anxiety, wondering if the graft would take, if infection would set in, if all this suffering would be worth it. For most of Gillies' patients it was. The tube pedicle worked. It rebuilt faces. It gave men their lives back. Looking back from our modern era of microsurgery and tissue engineering, it is easy to dismiss the tubed pedicle as a crude, outdated technique. But in its time, it was revolutionary. It was the difference between a life hidden in shame and a life lived in public. It was the difference between permanent disfigurement and functional reconstruction. It was the difference between despair and hope. Harold Gillies did not just invent a surgical technique. He invented a way of thinking about reconstructive surgery. He showed that with careful planning, meticulous technique, and patience, even the most devastating injuries could be addressed. He demonstrated that surgery was not just about removing disease or repairing acute injury, but about rebuilding what had been destroyed, about restoring form and function, about giving patients back their place in the world. This philosophy continues to animate reconstructive surgery today. When a burn surgeon rebuilds a child's face destroyed by fire, they are following principles Gillies established. When a hand surgeon reconstructs a thumb using tissue from the foot, they are applying lessons Gillies taught. When a breast cancer surgeon offers reconstruction after mastectomy, they are extending Gillies' insight that surgery can restore not just life, but quality of life. The men who came to Queen's Hospital in Sidcup between 1917 and 1925 could not have known they were participating in a medical revolution. They were simply trying to survive, to find some way to live with their injuries. But their courage in undergoing experimental surgeries, their willingness to trust Gillies and his team, their patience through months and years of reconstruction, made modern plastic surgery possible. Every patient who benefits from reconstructive surgery today owes a debt to those World War I veterans who served as both patients and pioneers. They were the ones who proved that faces could be rebuilt. They were the ones who demonstrated that tubed pedicles worked. They were the ones who showed that even the most severe disfigurement was not a death sentence, that medicine could offer hope where before there had been none. The tube pedicle surgery was never actually banned in any formal sense, but it faced skepticism, resistance, and dismissal from conservative elements of the medical profession who viewed it as too radical, too risky, too experimental. What changed their minds was not arguments or theoretical papers. What changed their minds was results. Men walking out of Queen's Hospital with faces, men who could eat, speak, breathe, and live, men who had been given back their humanity by a tube of living flesh and the surgical genius who invented it. That is the real story of the tubed pedicle. Not just a surgical technique, but a testament to innovation, courage, and the refusal to accept that some problems are beyond solving. Harold Gillies looked at the mangled faces of World War I and saw not hopeless cases, but surgical challenges. He invented techniques, trained surgeons, documented methods, and created a specialty. He transformed surgery from an art of cutting and removing into an art of rebuilding and restoring. And it all began with a simple decision during an operation in 1917 to sew the edges of a pedicle flap into a tube. That decision rebuilt faces, saved lives, and changed medicine forever.